Welcome, everybody. Before we get started, while we're waiting just 2 minutes for people to join, we're going to do our usual box breathing. And I can read it out while if people are on the phone and having trouble. So you're going to breathe in, hold, exhale, hold, inhale, 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 hold. Then we'll do one more round and then exhale, hold, inhale, hold, and our last exhale. And just a reminder for everybody, box breathing has proven effects to improve stress and anxiety. It improves focus and mental clarity, which is why we love to do this between our meetings. It lowers your blood pressure and heart rate, helps us sleep, regulates emotions, and has some also uh, effects on your pulmonary uh, force ex expiration that and other medical things that they're still studying, but it's used by the Navy SEALs in their training and kind of throughout their work. So very, very great technique for people to use outside of here as well. I'm going to turn it over to Julian Liz.
Hi, everyone. Thank you for joining us today for our March 3rd Surge Capacity Focus Area session. In today's session, we're really going to focus on planning for staff resiliency during and after a disaster. We recognize that none of the response can occur without a staff that is well resourced and well taken care of during some of these events. So we really wanted to take some time and focus on that for today's session. Next slide. This is our normal acknowledgments and disclaimer, just a little bit about the Pediatric Pandemic Network and who supports us, which is the Health Resources and Services Administration out of the U.S. Department of Health and Human Services. There are two cooperative agreements that fund us, and 0% are financed with non-governmental sources. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. Next slide. Here is the learner notification for the requirements to claim continuing education. This will be provided to you after as well. Next slide. This is our normal announcements. We're happy you're here. We are recording. The recording and slides will be posted online. If you have questions throughout the talk today, go ahead and put them in the Q&A box or the regular chat box. And we are offering CEs for physicians, nurses, and social workers, and MOC Part 4 is also available for physicians. The current priorities that we are working on right now is the Drill 1 data collection survey and Drill number 2, and I know Julie will touch on that a little bit later. Next slide. The objectives for today's session is to describe the unique stressors and risk factors affecting staff wellness and pediatric hospital disasters, to identify individual, team-based, and organizational strategies that promote resilience and psychological safety for healthcare staff during and after pediatric disasters, and to develop an actionable framework for integrating staff wellness practices into pediatric hospital disaster preparedness and community response plans, including immediate response and long-term recovery phases. Next slide. So we did our welcome intro and box breathing, and I appreciate you all doing that with us. It is a nice opportunity. I know we go from meeting to meeting sometimes, so to be able to take a breath in between a meeting is always welcome as far as I'm concerned. To start us off, I'm going to go ahead and turn it over to Kira and Tona, who are going to talk to you about staff wellness and resilience. So I will go ahead, Kira. I don't know if you or Tona are going to go first, but you guys can go ahead and take it away, and Julie will advance the slides.
Okay, thank you so much. Hi, everyone. I'm Kira Mosseth. I work on research and education and sort of disaster response with Tona and Chip and a team, and I'm happy to join you all here today. I'm going to kick us off and then pass it over to Tona. Do you want to introduce yourself right now, Tona?
I'm Tona McGuire. I work with Kira and Chip across a variety of places, and I've been many places in the world with Kira on disaster response. So,
Also for fun, sort of, but
and
mostly
also for
disaster
fun.
responses. Yes. Next slide, please. Okay, so just so that we're all on the same page, I think that it's really clear that at baseline, when we look across sectors in terms of some of the data, healthcare workers are at highest risk of burnout across the population. So the range of sort of the prevalence range for people in healthcare is already really high in terms of burnout, compassion fatigue, and some of the outcomes that are a little bit dangerous when it comes to the workplace. And when we go through a surge event, those outcomes are exacerbated. They are sort of highlighted and they shed a little bit of light on the baseline level of sort of people's functioning. So it's a little bit of an overwhelm that can happen. And it's really, really clear that it is going to take more than just individual go home and yoga our way out of this sort of tactics when it comes to promoting provider health. It is really not going to be effective if hospital systems and leadership within those systems say, you know, we really care about you and we want you to take care of yourself. And yet the policies and the staffing and the resource allocation is not consistent with that. So just to get us going on a baseline here. Next slide, please. Outcomes related to surge. I just mentioned burnout and compassion fatigue. Moral injury is one that's been much more recently studied. There are some really great meta-analyses about moral injury across groups, and it's pretty intense. It's extreme. Guilt, shame, rage, betrayal, a sense of not being able to practice the way you believe you should be able to practice, and feeling really helpless uh, in the manner of like to the extent that you're not supported in being able to do the kind of work that you believe you should be able to do to care for the people in the way that you would like. So that's a really intense outcome that's pretty common and increasing in frequency. And then secondary traumatic stress and depression and PTSD are also sort of in the running for common outcomes when it comes to surge, sort of results of surge when the systems are not in place to support the providers as needed. Next slide, please. So, as I mentioned at the very beginning, we're going to break down just a few high points from the literature. We tried to summarize everything from the last like 3 or so years that we could find that highlights individual best practices, leadership and work team, sort of that group level best practice, and then hospital and organizational system best practices. Next slide, please. This is not going to surprise anyone, I don't think, on this call. The sort of collection of ideas. There's nothing surprising here. It's really about intentional active coping, setting boundaries that work for you, working on workplace boundaries as well as sort of really differentiating between home and work, protecting that off time, protecting that downtime, and focusing your off time in activities that restore and recoup some of the energy that comes out during the work experience. So there's lots of sort of these tried and true kinds of things, tried and true. I know I mentioned yoga, but physical activity and physical exercise, just movement in general, is going to be one of those things. Deep breathing, time management, really focusing on some mindfulness or meditation or practices to keep you anchored in the present moment when you have a break between patients or between shifts before you head home, that kind of thing. Next slide, please. So for team and group leadership, just a sort of summary of recommendations. I think that the takeaway from this slide that I would really want to express is that it's really important to facilitate on a group level, people being able to process and share their experience. Tona and I would not sort of unilaterally recommend group debriefing. We certainly wouldn't want to require anyone to participate in that, but it's really helpful to facilitate the opportunity for people to have a chance to discuss with their colleagues, engage with social support, um, to to share ideas with each other, and sort of really validate what people are going through. It's not helpful to sort of draw a silver lining around things and say, we're such a strong team, we've got this. And also at the same time, people are falling apart. Validating the challenges and being truthful and transparent about the realities of the situation, and also providing supports where you can. It's not about ignoring the truth and the transparency about the challenges of the work in a surge context, for sure. This really also comes down to, in terms of the data that have been collected on equitable workload and staffing ratios and changing things, shifting things, being willing to adapt things on a group level so that you're not having a couple people bear the lion's share sort of the load when it comes to workplace responsibility. Anything else you want to add on this, Tona? I'm going to switch to organization, I think.
Nope,
Okay.
that's all good.
Next slide, please. Okay, so there's two slides on organization and system levels, and that was really intentional because I just really wanted to emphasize how important it is that organizations back this up with sort of walking the talk, as we say. So there's a couple issues here. Number one is feeling valued. Healthcare workers need to feel valued, and that comes with feeling safe at work, having physical space that is safe and where you have PPE that's appropriate. This is about not business as usual during surge, recognizing that changes do need to be made and they need to be supported in terms of resources top down. This is about clear communication and protocols with what happens to those scarce resources and who gets what and why, so that people aren't feeling like the onus of that decision making is on them when you're in a scarce resource or a crisis of care scenario. And then creating and sort of administratively supporting policies to improve working conditions. And again, the term is transparency, being transparent about the challenges and what you know and what you don't know. There's some really interesting research that says, sort of leadership style tends to be play it close to the vest and not share. But in fact, in a surge or a crisis standards of care type of situation, staff morale is certainly improved when there's transparency about what the status of things are and not pretending everything's fine here when in fact from the individual work staff experience, it's not fine here. So really having those things be meshed and consistent with each other is important. And listening to nurses is important too. Next slide, please. And then finally, encouraging those and sort of facilitating the opportunity for teams to talk and get together to share experiences, improving access to mental health support, whether that's through an EAP or additional programming and training, management of workload, really from a policy level down, establishing the norms about what that's going to be, and then facilitating open communication. I pass it over to Tona. Next slide.
Next slide, please. I'm going to talk just for a few minutes about kind of a unique approach to this wellness and resilience among staff, among providers and first responders in particular. And we know that people that go into healthcare, people who volunteer to respond to disasters are a pretty hardy group, pretty resilient, but they're not impervious to the risks associated with their role. And just like survivors in disasters and crisis events, all the literature across the world shows the kind of the more you're exposed and the type of exposures, the greater the risk for you. Not only in terms of the things that Kira was talking about, but moving on to more specific risks like actual PTSD. Next slide, please. And so this is a project that we have tailored a little bit this year. This is year 4 of our SciStart Triage Learning Collaborative, and we are adding APD to that, specifically focused on providers who are dealing with pediatric injuries and deaths and pediatric surge in some sort of large event. And it breaks down into these 3 components. So the anticipate part is creating overall a plan for yourself ahead of whatever the event is. And it starts with an active coping and exposure model, anticipating what would be the hardest for you. And that's not the same for everybody. What was hardest for me in Haiti, for example, was seeing children who were the same age as my toddler grandchild. But that wouldn't be the same for my coworker. So what is it about your role that really, really gets to you? Back up, please. Thanks. And then how can you tell you're impacted? What are your stress signs? And from that, building a coping plan, this active coping plan. What resources might you need? What might you need to add? How do you know at what level that your stress is that it's going to really put you at some risk? And then the deter part is actually monitoring these exposures that put you at risk for something like PTSD and activating your plan. Next slide. There we go. So there's a system, and when you have signed up for APD, for the SciStart Responder, you will get a little text message that reminds you every so often on your phone. It's been a while since you've, entered a triage. We recommend that, in times of kind of normal practice, that people might triage once a week or every couple of weeks. If things start to ramp up, you would do it more often. If the system picks up that your exposure level is going up, it will send you a reminder that says, it's probably time to activate your resilience plan. What are you going to do? Who are you going to connect with? Socially, how are you going to, what things are you going to bring to your toolkit to help you manage this risk exposure for yourself? Next slide, please. And it has a My SciStart button, so you can actually see your trend over time. One of the things that people are uncomfortable about, not only in healthcare, but in like law enforcement, for example, or the military, is sharing information about what they perceive as some sort of mental health impact or weakness. This triage is seen only by the person who is doing that. We recommend that people share with their colleagues who understand kind of the risks and the challenges most directly. But only you can see this, but it allows you to kind of see the trend. And then again, to sort of mindfully activate your personal plan, whatever works for you, and think about whether you need something additional. Next slide, please. So although the individual triage is not accessible by anybody other than the person who enters it, leadership with certain permissions can access aggregated and de-identified data. And that allows them, as Kira was talking about, to sort of strategically increase support where it's needed. We did this through the Department of Health during COVID. And, the aggregated data can be role type. Nurses, physicians. In COVID, it was respiratory therapists who were really struggling often with kind of the stresses of the job, and also location. The ED may be a hot mess, but the PICU is fine. So it provides information to leadership at the highest levels so that they can be strategic and really get in there and offer some additional support to their workforce, which increases the capacity for the workforce to hang in there and keep going instead of opt out or burnout. Next slide. I think that's it for us.
I really loved hearing that. And I'm gonna talk to you about willingness to respond, which actually ties in very closely with what Kara was saying. So really excited that you spoke about a lot of those things, Kara. And then we'll go through a novel approach that we used during the pandemic to monitor staff mood. Next slide. So, just a couple of quick things on willingness to respond that kind of tie back to another way of looking at, I think I like how Kara put it on moral injury and things that impact that because they all go hand in hand. This is a study that was done in 2020. I'm lying to you there. It was 2000, I think 18, because right before the pandemic. It was 10 hospitals. And what they were asking is, would you be willing to respond to a disaster with these circumstances and looking at different disaster scenarios that might play out? And then they gave them different explanations or circumstances under which that they might respond to each of those disasters. So for natural disaster, would they respond under A if I know my family is safe and taken care of, for example? If you look kind of through the columns of A through J, you see that A, D, and F were the most prominent. And again, that varied depending on the type of scenario that was there. But if we go through A through J and just kind of see what each of those is, A is if I know that my family is safe and taken care of. So, you're willing to respond, and your stress level is not only going to be dictated by what you're dealing with that's right in front of you, but your other fears that have to do with your family and your community that or dependents that you need to take care of. So making sure that from a disaster preparedness level that all of our responders are doing self-preparedness first. D is another big one. If I'm trained to handle the situation, and Kara brought that up as, am I able to come in and do my work? Am I doing the work that I typically would do? Is this out of the ordinary that I do? If I'm not able to do the work that I'm expecting that I'm going to do, then that's going to also place undue stress. And then we also talk about safety, personal safety. So, do I have the right PPE to protect myself? Am I going to get antivirals, antidotes, vaccines? So really important to help our staffing wellness, but also that plays into their ability and determination to actually come and respond. Next slide. And then one more study that was done in 2011, and this was out of Johns Hopkins, is a scenario of a radiologic event. And this was a survey again that went out throughout the hospital, and they had about 34% clinical and 66% non-clinical staff that responded, and 32% of those actually knew what their role would be during a disaster event. In this makeshift radiologic event, there was 61% who were willing to respond to the disaster to help at the hospital. 72% said they would come in if they were required, but only 51% said that they would respond regardless of the severity. So half, which I think is actually a very high number. Things that played a role in people's kind of willingness to come in was the likelihood that their colleagues would respond as well, their ability to be safe, safely get to work, and also stay safe when they're at work. And then really two big ones, number 4 and number 5, their ability to perform their duties. So if they are not able to come in and actually do what they're expecting that they're going to do, or have an understanding of what their role is, then they're going to feel like they're going to be less willing to come in and actually respond. And while they're there, if they're having an impact, then they're going to feel better about the work that they're performing. So are they trained? Are they able? Do they know their work? And then do they feel like their work has an impact? And a lot of that, is also up on us as in our preparedness and just understanding that we need every single staff that's there from everyone from our EVS staff to our security staff to our clinicians. It's the full gamut, and each of them has a role that's super impactful. Again, going back to that my family is prepared. And then a lot of what we're talking about today is that kind of our psychological preparedness from an institutional level. So all of these play a role in that. Next slide. So kind of going back to how do we monitor some of those things and how do we take care of our staff? And during the pandemic, we found out early on at Hopkins that, I think everyone recognized there was a lot of anxiety, a lot of questions, a lot of fear of unknown as well. And we said we need to not only do we put up our instant command and we had really great top-down communication of what was going on, what was happening, changes that were happening. But we wanted to have a reverse communication too that was going to be effective for us to know what was happening on the ground. And we did this in a little bit more of a micro level in the pediatric emergency department and worked with our department of psychiatry to help us with building this. Next slide. We had a survey that was placed, and the objective was to understand and track our staff morale and their job satisfaction. So, do they feel like they are doing their job or can do their job and have impact in their job? Put in a much more simpler term in the survey. And then we were tracking their responses and to see how we could help and support them during that time. Next slide. We did this through a survey that went out every week by email. This is exactly how the survey looked. We also had QR codes throughout the entire emergency departments on computers, on walls, on closets. And it was just a very simple, very easy, takes a second to do, where they would respond with their scale, their Likert scale of 1 through 5, of whether they're sad or happy, angry and irritable or peaceful, exhausted or energized, fearful or confident. We use those 4 domains as our emotional domains. And then the question, are you satisfied on the scale? How satisfied are you with your job right now? Not satisfied being 1 and completely satisfied being number 5. Next slide. And then recognizing that our responses are going to be somewhat biased whenever you have a survey like this. So people that are responding are going to be people that might be feeling one way or another. We did want to track this kind of over time, and we did actually add in like mini morale boosters the best way that we could, whether it was candy or, pizza or things that, were more infection prevention control acceptable during the time to help kind of during certain weeks that might be a little bit rougher on people. And I'm sorry, I could not get the numbers out of here, but if you look at this, you see that the dash line at the kind of the lower line kind of stayed pretty steady throughout, and that was our overall job satisfaction. And this was kind of we didn't in this slide. I'm not showing you the differentiate in between the different staffs, but kind of across the board, we stayed pretty steady, not too much of a difference. We did see some difference within angry, peaceful, and fearful and confident. So the lower number is the angry and irritated and fearful, and the red and the blue. And you see those kind of slightly go up over time, but not looking at the overall trend, but weekly, we would look at each of these responses that we received, and we would go back and show them to our department leaders and go through and the questions and see how we could support the department at a more micro level during that time. Next slide. Then we also took they had after the survey, they had a box that they could put in questions, they could put in comments. And we afterwards kind of put them in groups just so we could illustrate kind of the type of feedback that we were getting. there was a lot of questions about exposure and what do we do about PPE and how do we maintain our if we got exposed to a patient, how do we manage that? Some of these they might fall under multiple categories, protocols or um, safety. There were a lot of questions around and comments actually around breaks. And this again goes back to what Kara was saying earlier, making sure that you have staffing, understanding that if you're not staffing currently, we saw after the pandemic, one of the first things that happened was that we were losing left and right nurses because I think they were just burned out and morally exhausted from this. And this comment is a very clear illustration of that. Please bring back lunch nurses. They are great for morale, improve job satisfaction. So they were telling us exactly what they needed and what they wanted from us. And staffing, we need more support staff. So again, throughout this time when there was a lot of fear and angst, having kind of that regular staffing was really, really important to them. Um, there were questions, just kind of comments specifically just around morale. They would let us know, right now things aren't so great. Comments around pay and compensation. Department protocols that we could address pretty easily during those weeks. Notices that went out in our little huddle meetings and from the leadership down. So that was really nice to have interdepartment protocol questions that we could go through and then some miscellaneous. But overall, it was just a really nice way to be able to address all of these issues within each department at a personal level for all of our staff and have them have an anonymous way of giving us feedback on how they're doing so we can make these changes to help them throughout that time. Next slide. And then we'll take, and then there's, of course, not perfect and how any survey ever goes out. So, the staffing that was there, anyone that walked through our department could use that QR code and put in their assessment and their questions and comments. Things fluctuate from day to day, so it's hard to tell always exactly what's causing it. I think we thought that the questions and comments were most useful in giving that feedback to our leadership in the hospital and also helping our staff on the ground. Yeah, and we'll take questions afterwards if anyone has any on this. Next slide. We'll move on to David and Rachel, who we're really excited to have here today as well.
Afternoon. I'll introduce myself. I'm Rachel Lamsa. I'm the Quality and Patient Safety Manager, and I also oversee our peer support programming at Children's and have built a great partnership with David. So David, take it away.
Yeah, I'm David Kopp. I'm the Manager of Spiritual Care at Children's Minnesota, and I think I'm going to take the first part of this, and then Rachel is going to kind of take the second part. So I'm going to kind of walk us through a couple of scenarios that we've been through recently. And if you go to the next slide, we can jump right in. I'm not going to spend a lot of time on the patient side of things, but just enough to get a sense of how it was affecting the team, so we can talk about team care. Both of these events that we're going to talk about were national news, and so they may be familiar to you. August 27th, that was State Fair Week for us in Minnesota. We had a mass shooting take place at the Annunciation Catholic School, not very far from our Minneapolis hospital. As soon as the first responders were arriving and we knew that we were going to start receiving some of the kids as patients, along with Hennepin Healthcare, we activated our hospital incident command system, and that works on a variety of different levels. I don't know if y'all have talked about that before, but for us, the direct impact was that our Director of Child and Family Services is part of that team, and so she was able to kind of get our spiritual care, interpreter services, child life, music therapy, all of these groups working together to take care of kids as well as their families, and then we could transition over to taking care of staff. As soon as the trauma team activation was called, we had a chaplain headed to the emergency department. She called for backup, and before we really even knew what we were doing as part of the Hicks system, we were already getting families organized in our chapel because we knew there needed to be a place close to the ED for them, so that they could be that they could have a place where they could feel safe. So we helped get the families to our chapel while their kids were in the ED. We prepared it, got it ready for them to have kind of a peaceful place. Our plan actually called for using the cafeteria, which is right there at the main entrance and has a lot of glass windows and a lot of light coming through and a lot of exposure to the street. And so that just didn't feel as safe. And so using the chapel seemed to work out better. At that point, the rest of Child and Family Services mobilized for family and sibling support. And as soon as the families were taken care of, and we knew that the kids who had come in and had gone through the ED were taken care of and families were reunited, that's when we were able to begin with the staff care. So we can go to the next slide. We instituted several staff well-being interventions that day. As soon as the families were out of the chapel, we set up the chapel for staff. We brought in some art supplies. We brought in some sort of things that you can do ritual stuff with, like a bowl with water in it and melting paper for people to write down feelings they wanted to let go of, and they just let it float away in the water. And there were some awfully strong feelings in that water and a lot of curse words. But it was one way to let go of immediate feelings. We had one of our chaplains brought one of the therapy dogs onto the ED in PICU for staff care, and one of the ED nurses just knelt down and started petting the dog and said, "I can't talk about any of this right now, but I do need this." And it was exactly the right thing for her because the connection with the dog was real. Finding words for all of it wasn't. We have a thing when there are deaths of patients on units where we take a care for staff basket to the break rooms, and we took them to the break rooms on the affected units here, not because of the kids, but because of the staff. They were in need of some additional care that involves tea and a candle and some remembrance stones and snacks, food, things you can actually use to get your blood sugar back. Along those lines, later in the day, we brought a coffee cart and cookies up to each of the units. And then Rachel could talk more about setting up the staff well-being room, but that's something that we set up that day and enhanced in the days to come. Got one-to-one peer support conversations going. We had our Native American liaison contact us, and you can see the text message there on screen sent to one of our chaplains offering to just come and do a smudging, maybe in the chapel, and maybe a smudging for any of the team who felt like that would be a helpful thing for them to reset. And of course, we arranged for that to happen. And so it did. It happened the next day. Next slide. In the days to come, we arranged what we call Tea for the Soul on each of our affected units, where we bring in art activities and the different things people can do with their hands, and quiet time, massage pads, things like that into the unit itself, so that staff can take a few minutes of break whenever they feel like they need it. Team peer support conversations, Rachel can talk more about that.
Yeah, David, if you don't mind, I'll just talk about that right now.
That sounds great.
Couple peer support conversations we had the debriefing of the team that cared for these kids, that we kept very separate and intentional to those staff who took care of those kids. But we also had some team peer support conversations for those that had kids or neighbors or others in their personal lives that were connected with the school, and it was affecting their ability to come and show up for work in the way that they normally would. And so as I was listening to the conversation earlier about, feeling safe at home or having this, their kids be safe, this was something that, because it was so close to our Minneapolis campus, many of our staff didn't just have effects based on their area of care, but there were people throughout our organization that were affected by their community and family connections to this. So that is something that we learned, is to just make sure that we are doing team conversations for multiple purposes and multiple groups that are affected in different ways. Thanks, David.
Yeah. And one of the things that happened the night of the shooting was that there was a large gathering in a park near the church and the school where it happened. And a lot of our staff went to that, and we connected with each other. It was a candlelight vigil. And while I was there, I just happened to run into Mark Gorelick, the president and CEO of Children's. He was there along with several other leaders from Children's because they couldn't not be there for our neighborhood. And it meant a lot to see them there. It was about a week later, it was the 4th of September, we hosted a Tea for the Soul on both campuses, a large one that was open to all staff. And immediately following that hour or two of kind of intentional activities, our new CEO and president, Emily Chapman, and the Staff Wellbeing Collective hosted a vigil. And it included an 8-minute period of silence honoring the 8 patients that we treated. And it was a way of fostering a shared healing experience. We had a Teams meeting going on at the time so we could see on each campus what was going on the other campus. And to have kind of a big circle of people holding candles in one room and then seeing on the screen in front of them another large circle of people holding candles, it felt like across the 2 campuses we were all united during that 8 minutes of silence. And just being able to remember, it was something that people pointed to afterwards as one of the more powerful things that happened during that vigil, and it helped people to feel connected and centered. We did set up you talked about team support rooms. We did set out artwork and note cards, the melting paper again for stuff you want to let go, the note cards for stuff you want to write down and share. So those are 2 of the things that we tend to use quite a bit, and began putting together a 30, 60, 90-day plan for support. Go to the next slide, and that'll be the last one that I'm talking through, and Rachel can kind of take it from there. The other big national news thing that happened was kind of over time. The Metro Surge that started happening in Minnesota over the last several months has taken a huge toll on our staff. We have employee resource groups, thankfully, already in place. Our ERGs, like the Familia for our Hispanic staff, the Muslim Employee Resource Group, Merge, the Asian ERG. All of these have people who come from immigrant communities. Some of them have been here 20, 30 years. They're citizens, but that they are also connected with people who have been directly targeted by ICE and by DHS, border patrols, simply by the color of their skin. People who are coming to work carrying their passports, even though they're citizens, and worried about whether they can take their kids to the grocery with them, so they're not doing that anymore. They're stopping on the way home and picking stuff up without letting their kids out of the house. So lots of stress, lots of potential for moral distress, moral injury, and we're going to be looking at some generational trauma coming out of this. So some of the stuff that we did here at the hospital involve working through our employee resource groups, sharing articles in our StarNet, which is our internal web page for employees. We had letters of support from all tiers of leadership going out to staff. We had conversations within the community. On Friday, January 30th, there was a citywide march and protest, and it was a strike basically. And we made allowances for staff who wanted to participate in that and made sure that people leaders knew not to penalize folks who wanted to do that, and make sure that we made staffing arrangements so those who needed to take that time off were able to. There was a national vigil for Alex Preddy several days after his killing, and we participated in that. For nurses who couldn't get out to the community vigils, we held vigils on each campus. And you see pictures here of some of the luminaria that were created on our Minneapolis campus during that vigil. We had, again, the luminaria, the melting paper, the cards and letters for the nurses at the VA because they were Alex Preddy's closest co-workers. So all of these ways that we're trying to kind of support staff. And Rachel, I'm going to turn it over to you for the next slide.
Yeah, thanks, David. And so, as you can see, we didn't just do one thing, because one of our greatest learnings, I think, over the last couple years, particularly this last year, has been that we're better together, we're stronger together. And so one of the things that we have done, and I don't know if there's anyone from Dallas Health Children's on, but we replicated your RISE program and have created what we call our Staff Wellbeing Collective. So if you go to the next slide, that is really many departments joining together. David's spiritual care team, my peer support programming, ethics, our organizational development and learning team, our physicians well-being committee, healthy work environment, many of us that were already trying to address employee well-being in lots of different ways, finding out that we're better when we talk to each other, when we turn and connect with one another, and can provide a multi-layered response, particularly when we have big stressors on our healthcare community, whether that be the two examples you heard, or smaller but yet very impactful things like unexpected patient deaths as well. And so this is something that we've had in place now since last October. We officially rolled it out. But as we were putting the plans together, as always, that was when the Annunciation school shooting happened, and we got to kind of do an experiment of what it looked like to come together before it was official. And I think it just really underscored for many of us as leaders how important that is. I also wanted to highlight one of the interventions that we have implemented that I think would be helpful for all of the teams is salons, conversation salons. We call them peer support salons, but really it is a conversation with one another about what's on your mind, about practice, and making sure that there's equal airtime for all those individuals. But the reason that we implemented this is that we were finding we did not have the muscle of turning to talk to one another post-pandemic. We had gone through this big disconnection as a healthcare community. And so we wanted to build that muscle before things went poorly. We wanted to make sure that we were building the ability and to have community, whether that be within our team or within our organization with others. And so that was a really strong initiative that was going on as we pulled together the Staff Wellbeing Collective. And although they were meant to be proactive and build that, we've also found them helpful for our ERG groups that David was mentioning as a way to kind of support conversations, to be able to hear one another and connect with one another throughout all of this. And so if you go to the next slide, we are still working on what it looks like to come together and what it looks like to measure our success, as this is new to us as well. But I think the biggest thing that we're really hoping for is that our employees have increased awareness of all the things that we have to offer, that 24/7 support through our LIRA, through our spiritual care, through our peer support programming, that there's lots of things that they can do, and to make it easy for them to utilize it by a one-stop shop. Hey, I need some support, and we can help them figure out what and where to get that connection. We really want to see reduced moral distress and burnout indicators. And again, we really believe that a big part of that is making sure that our employees have community within our organization and feel heard. And so trying to continue those interventions to address that. An improved ethical climate. Our ethics department is very supportive of all of this work. And of course, psychological safety. The ability to speak up is one of those things where if it's not there, if you can't say, hey, I'm not doing well, or hey, this really stinks, so we need more support. If you can't say that, there's not a culture of safety. And so this is really a thing that we learned as a children's hospital as well, that our peer support programming and our employee well-being programming needs to be really closely tied with our culture of safety work, because our employees are our greatest resource, and they're how we take good care of kids. We also really have, as you can see, really enhanced our cross-departmental collaboration, patient safety, spiritual care, ethics, HR. We often work to really in silos. That's feeling like a really cool measure and a really cool way to continue to advance this work. And then one of the things that we continue to struggle with is provider engagement. It's hard for our clinicians to take time away for this stuff. And so that is something that if you are doing really well in that space, we'd love to hear more about how we can support our providers. And that will be a measure that we will be measuring moving forward. David, anything to add in that space?
No, I think I mean, we haven't talked much about child life and music therapy, but we've worked really closely with them as well in order to try to provide experiences for staff that are playful, that have kind of meaningful music to them, and music therapists know how to do that. They know the right things to sing and to play during some of the vigils and the events. And so trying to integrate kind of a holistic approach to wellness that involves all of the senses and all of things that allow for feelings to get expressed and not stay bottled up. We think these may be proactive ways that we can help reduce some of the moral distress and moral injury that can come, and certainly help to reduce some of the secondary trauma.
Rachel, if you don't mind, I would love to comment really quick on the last bullet about the improved provider engagement part. So once what we realized during the Annunciation School shooting, given the fact that the shooter was killed on scene, the entire episode was only 2 minutes. The surge response, the immediate surge response within the ER really lasted about like 2 to 3 hours. Right, the immediate response was quite quick. Of course, all the aftermath afterwards went on for a very long time, but because of that reason, the surge response ended within the same shift time as the providers that were still in the ER. And so it puts you in this unique position in which what we learned from the debriefs was how do you manage the well-being of these providers that are still in the ER? How do you manage the well-being of the staff that's in this ER? Because when we think about disaster surge responses, sometimes we think hours, we think days, we think weeks, but we don't think what happens if it's within that same shift. And so our leadership was there, and after the surge ended, they told the providers, like, we have people ready to go. We can definitely have someone come in and work. You guys, you're more than welcome to leave. How are you doing? And it is almost natural for us as providers and staff in the ER to just take these moments and say, nope, I'm fine. Nope, I'm fine. I'm good. I have more patients to see. I have to do. And what we learned from our debriefs was that we really should not maybe give an option. What we should say, we need to have a plan in place in which we say, if a surge or disaster event ends within the same shift period as a provider or staff, we will have a backup plan in place in which we will say, you are now excused, the MCI is over. We have staff who is coming in to replace you. Finish up your work, finish up your notes, finish up whatever you have to do, but another person is coming and you have time off. Determining what kind of length of time off obviously can vary between hospital and health system, but we at this moment say whatever time you need, you can have. We then, because of that learning from Annunciation School shooting, when we had Metro Surge and ICE occupation, we were very
transparent with our providers. And we said, and staff, if you at any point feel unsafe or uncomfortable coming to work, you are more than allowed to not have to come to work. You don't have to put in PTO. You don't have to ask for an excuse or provide a reason. You should feel safe in what work you're doing. Please do not come to work for that reason. And we have a process in place in which we can provide support and make sure that we have staffing needs at all time. And that was really a direct response from Annunciation School shooting to make sure that our staff and faculty really do feel safe afterwards. One of the nurses said directly to me during the debrief was, after the MCI event ended, one of a chronic abdominal pain female came into the ED. She's there consistently. And when she was complaining of her abdominal pain, I had zero emotion. I didn't feel anything. In fact, I was kind of irritated. And she's like, I knew at that point I should have not been working anymore that day. I should have gone home, and I didn't. And it was wrong. And, she broke down crying. And I think it's really important for us to kind of think ahead of time and plan for these moments, that we really should have a plan in place for our staff and faculty. Go ahead, Rachel and David.
No, I really appreciate those comments. And I was just looking in the chat about the nursing contract that has a process for that. I think that's really, really important, and something that we don't yet have at Children's Minnesota to think about. We do the best we can for each other, but it's not a standard process. So I really appreciate that.
That's great, Marie. Yeah, that's really great. Maybe I would love to connect with you to kind of figure out what that plan is, and how it's worked for you, so that maybe we could potentially see if we could implement that with our group.
One of the other things that we were focusing on, especially with Metro Surge, was our interpreters, because our interpreters often come from the same communities that they are interpreting for. And for so many of them, they're coming from communities that are have been experiencing kind of direct targeting from ICE. And so that they're having to maintain the professional boundaries at work, while at the same time working with people who are really struggling with the same stuff they are. And so in order to make those connections, but keep it professional and make sure that the medical care is still the primary thing, that they needed additional support. And so that's one of the things that we haven't quite fully figured out, but we've been working on. I know that a number of them have been allowed to do things with doing shifts from home and being able to do more telehealth work, but it's one of the things that we still are wanting to figure out, because we've noticed that's a need.
Yeah. No, thank you, everybody. You guys please feel free to come off of your mute and ask questions, or if you have comments, or you have things at your hospital that you do that is unique to help staff morale. I'm going to ask David a question, if that's okay. I love some of the methods and techniques that you describe for helping staff, like having the melting paper and letting go of emotions. At hospitals that don't have, a lot of these things we have implemented at hospitals because they're children's hospitals, and we have the pet therapy and the music and all that. At a smaller hospital doesn't have it, or a community that does not have all of those, what are other things that they might be able to implement to help staff? Instead of using it for patients, use it for staff, but simple and easy, that we don't have already.
Well, the nice thing is that all of us were kids once. So anything that works with kids will generally work with adults. Yeah, I mean, I say that kind of humorously, but it's largely true, because we do respond to things in ways that go all the way back to childhood responses. And so if there are things that we can do, as adults, that involve some play, music, things like that, that really does help. I mean, Rachel and the peer support program talk a lot about the need for laughter, and about playing, and about making sure you stay hydrated, because you got to pee it out, cry it out, or sweat it out. And those are things that sound pretty basic, but it does help. And spiritual care, that's some of the stuff that we actually do spend a lot of time with. If you've got professional chaplains on staff, that's stuff we're all pretty familiar with.
Yeah, I would just reinforce that it is the simple things that matter and that it doesn't take a lot of resources. You know, the melting paper you can get really cheap on Amazon, but if you don't have that, you can write it out and then write on top of that and write it on top of that and black it out so that nobody can read what you wrote and throw it away or burn it or however you want to dispose about it. And it has the same effect. So, yeah, I would just reinforce that all of these things, sometimes we get caught up and it needs to be a big thing. But when we have our conversations, it's a hot cup of water and some tea that we are sharing and just having a conversation with one another. So trying even at children's to not over engineer it. Let's keep this simple. What can we do right now for our staff with what we have is the best way to do it.
Yeah, that preparedness ahead of time really matters. It's the same stuff that we do anytime there's a death on a unit. We're taking the same tools. We're not having to reinvent things.
Right. No, I noticed that, and that I love that simplicity. And then Chelsea Lama, if you want to come off of mute, feel free to. But looks like you're also at a rural facility, and might have some of the same issues.
And Amina, if you don't mind, I would like to add, David mentioned how we provided time off for those who wanted to attend some sort of citywide event. Typically in events that are of this scale, there is some sort of community response. There is some sort of vigil or, some event happening, and even allowing the opportunity for staffing to go and attend these and providing backup doesn't require any sort of object for the patient, but it does speak volumes, I think, to the staff that the hospital is willing to allow them to go do something outside of the hospital in order to engage with them for their own emotions and well-being. And it really does speak a lot. And I know that was well received.
Yeah, and it might happen naturally, right? But I think that having it come from the top institutionally makes a huge impression, and people feel safer that way. I agree. Thank you, Nita. I really appreciate your input here.
Well, recognize that people are part of a community, and the people who work in our staff are part of the community. So part of being good neighbors is allowing people to be neighbors to their neighbors.
Mm-hmm.
And
The
I
other
see
thing
it.
that I might highlight is how all of the hospitals came together. So when Annunciation happened, right, we sent them cards. When Operation Metro Surge happened, we sent cards to the VA who had lost their colleague, Alex Preddy. But then we received cards from a hospital in Washington to our nursing staff to encourage. And so, those little things go a long way. And even like these types of dialogues where we're with each other and supporting each other and how we do this well, I think makes a big difference. So thanks for coming together today as well.
Well, one of our slides had a photo of a little wooden heart. It's actually a large wooden heart that we created with a glow forge that we had just gotten through our child life department that we can use to create memory making items. And we took all of the notes that people had written and we had them laser printed into that large wooden heart, and were able to send that as a gift to Annunciation.
And Tony, you have sorry, Troy, have I can't read today, have a message in the comment if you want to come off of mute about the therapy dogs and music therapy.
Yeah, a couple things that I was thinking of. All the ideas you have all talked about, the tea, the music. I mentioned the aurora in her background. I'm a photographer and a fanatic on aurora because I finally got to see it in Indiana. But it's very calming. That's relaxing. And if you can have an area where you put all this together, whether it's for patients or whether you have it with all your caregivers, to me, that's super important. And if you can blend and mix a relaxing atmosphere and everything together, I love the idea. I've now my mind's just really going thinking about several of the things that you all have said.
I want an aurora projector now. That sounds amazing.
I can send you a link.
Yeah, I think my at Hopkins and the pediatric ED, they had put together a staff den that had a little like a relaxing chair and had a noise machine and to play music or machine noise, peaceful, calming noise.
I'll say that the reason a lot of this stuff works is because we've already got a lot of our child and family services and staff support stuff integrated into the wider hospital. We're not having to come in like during a crisis and nobody knows who we are. We're already on the units, we're already embedded. And so we're just kind of doing what we always do. And that makes a big difference.
Yeah, I think a lot of hospitals are familiar with RISE. They typically have RISE that comes from department to department, and I think they ramp that up typically for disasters. Does any, you guys mentioned a lot of additional approaches that I appreciate. And then Tona talked to us about the SciStart. Anyone have questions on any of that and how maybe you can integrate any of these into your planning? And is there a way that this could be, besides kind of having the awareness, having it as part of the disaster drills? Has anyone used some of the recovery resources during a drill?
And I'm glad you brought that up. We actually will be doing a regional exercise here in May within the Twin Cities, and therefore children's will also be a part of it. And we will be focusing on MCI. And our team has talked about, given recent events, that can be actually quite triggering. But an exercise, of course, needs to happen. We're doing a new MCI protocol. A lot of departments are involved in it. And so our plan is to do, they have town hall sessions within our hospital where everyone can sign in and understand, upcoming events and things. Our team is going to present at this town hall that we will be having a planned exercise in which we will have real patients simulating for an MCI as kind of a warning to all staff, because we really do want to make sure all staff well-being is okay. And then David and Rachel don't know this yet. We will be it was on the list of my to-do list, but we will be making sure that someone from the team is present that day so that we can make sure that not only do we have that integrated for a part of our exercise, but also we're actually there for the staff and faculty who may be triggered for this. And I think that's really important, and I'm glad you brought that up, for those who have just recently gone through some sort of event, but the exercises have to continue, the plans get done again, the protocols have to be updated. So making sure that we are looking at the response, that secondary response and trauma that could be triggered to our faculty and staff.
Thank you for mentioning that. It's good to know that it's coming. But also, one of the things that we sometimes do during simulations in the ED, at least I've done it a number of times when I show up for a simulation, is just remind people that even though this is a simulation, your body is doing the same stuff that your body does during a real one. And you're going to feel stuff that you might not believe you're going to feel because you know it's fake. You know it's a simulation, but your body isn't always going to know that because you're doing the stuff. You're going through the same actions, saying the same words, and your body will understand that on some level you're doing it. And so I always encourage people afterwards to just pay attention, even after a simulation, because it can be something that triggers you, and you wonder, why on earth did that trigger me? I knew that was fake.
Thank you guys for bringing that up. We have, I think, one or two poll questions for everybody, and then some things that Julie needs to share. For those of you in the Surge focus area, we've gone through several sessions now. We have one more left and wanted to make sure that we are covering what all of you are interested in. If there is a topic or an area that we haven't covered that you'd like to hear about, or something that you would like more in depth in any way, please let us know. And we'll take all these answers and plan out our next session. I know it feels like it should be summer already, shouldn't it? We want to move forward. And if you can't think of it now, you feel free to email any one of us. And as you're going through your plans and your tabletop, just shoot us a quick email and say, hey, really, we didn't do this and we need to. Okay. Thanks, Julie. And Julie put the email in the chat as well. Okay. We have some resources that were shared with us from the folks here, as well as from our mental health domain that we're going to be sending out to all of you. We'll also get it on our site. It'll just take a little bit longer to do that, so we'll send it out to you sooner. Julie, you want to take over?
Yes, thank you. Thank you to all of our speakers. That was really fascinating. Staff wellness leads to patient wellness. I think that's really the gist. And so hopefully you got a lot of really great tips to add to your plan, your disaster plans, and to incorporate in your children's hospitals. So some of the things that we haven't gone into a lot of detail about are the process measures that we've talked a little bit throughout the collaborative. And we wanted to go over these. There's been some questions. So when you do your drill, so you've done your tabletop exercise, and now a lot of you are doing your first drill to test the changes that you made during that tabletop or after that tabletop exercise. What we want to encourage you to do is choose at least one of the process measures. So one of these 4 process measures, you don't have to choose all of them, at least one. And during that drill, you're going to measure uh, the time or the number of patients or whatever is here in this second column uh, while you're doing the drill. Now, this is going to take a staff member so you need to designate a staff member to take the measurement. In the hustle and bustle of the drill, especially if it's a live disaster, then sometimes these are forgotten and they're pushed to the side. We totally understand that's going to happen. But if you're planning for the drill, you're going to choose a process measure. So say it is time from notification of event to activation of the incident command. What you're going to do is you're going to measure that first time of notification. So the first time that notification event was received by the facility. So that might be one person designated in the facility. That might be the phone call. That is for you to decide, your hospital team to decide what received by the facility means. But you're going to record that time of the notification. And then as you move forward, you're going to record the time that hospital incident command was fully activated. And then you're going to take the number of minutes between those 2 times, and that is the process measure value that you want to record. So how many minutes did it take between the time of notification of event and the time that incident command was fully activated. So that's how you'll read each one of these. This slide will be posted on the website with the remaining slides, and we will also put this on that website under Surge as well, so that you have a clearer image of how the process measures are laid out. And of course, if you have any questions, please, please, please reach out to that DNC PPN at austin.utexas.edu website. For those of you who have done your drill, hopefully you have completed the data collection survey. If not, it should be in your inbox. It was sent to all DRC hospital team members. If you didn't receive that, again, reach out and we'll send it out again. Couple of announcements in the last minute or two. We've got our last Surge focus area session next month. Cannot believe it's been a year and a half. We've really enjoyed this time. And so next month we will meet for the last time individually for this collaborative. We'll say that. And then May and June we'll meet as a full collaborative. More to come, what happens after June in the future. We have the Pediatric Preparedness Playback Series. A lot of you have been asking what happened in the Disaster Networking Collaborative. So we have put all of those sessions together with our education team, and we have this on-demand training for pediatric disaster preparedness. So that is C-suite engagement and support. That is gaining coming up with common disaster roles in the children's hospital, and then engagement in the emergency management landscape. You'll get, there's 10 education modules. There's CMEs and C credits, and then a completion certificate at the end as well. Coming soon, we're going to have the DRC dashboard. So not going to go into detail on this, but do recognize that those emails are coming, and this is really exciting as we get ready for future collaboratives. The National Pediatric Readiness Project Assessment for EDs is now open. It was supposed to open today. It is open. So go to pediatricreadiness.org. Make sure your hospital gets their information in and be a part of this national assessment so that we can really benchmark EDs and find out how to make ourselves better. To go along, one of the resources to go along with today is the newest PPN podcast, Ready Prep Go. Season 3, Dennis Wren has interviewed clinicians and others who were devastated by the impact of Hurricane Helene from Florida up through North Carolina. So a lot of really, really great interviews, but the first session is with Dr. Martin in Florida, and she really talks about like the effect of her and her family going through that and getting ready in her hospital. And if you are looking for CE credit, here's your evaluation link. I'm also putting it in the chat along with your code. Once you have that link open, you are welcome to log off, go to your next focus area session or your next meeting. And I'd like to thank everybody. Have a wonderful day, and we'll see you in April. Thank you again to all of our speakers.